So hello and welcome to our Ask the Expert session this afternoon. As I was saying earlier, it's very frosty here in Liverpool. Don't know what it's like where you are, but it is very frosty here. My name is Paula Hanford. I'm the CEO of PSC Support. We have these sessions at different times on different days. We want as many people as possible to be able to access the sessions live. But if you can't access the sessions, any sessions live, or you want to watch this session back, all of the sessions are available on our YouTube channel. I said a little while ago, so you might have caught it, but we've got 85 people registered for this webinar, which is amazing, I think, for 1 o'clock on a Wednesday afternoon. I'm absolutely delighted to be joined by Dr. Palak Trivedi this afternoon, and he did our last Ask the Expert as well. He's a regular at these events and one of the leading PSC doctors in this country. Dr. Trivedi is a consultant hepatologist at the Queen Elizabeth Hospital in Birmingham. He is the chair of the British Association for the Study of the Liver, Immune Special Interest Group. It's a bit of a mouthful, that. We call it the BASL SIG. And he is the chief investigator for UK-PSC. Today's session is a general session, a question and answer session, really about all things related to PSC. So please put your questions in the Q&A section. And please try and keep your questions as short as possible so we can take as many as possible. And just bear in mind that Dr. Trivedi cannot give individual medical advice, as always the case on these events. I'm sure you will join me in thanking Dr. Trivedi for giving up his time, very busy man, for giving up his time this afternoon. He's probably missing his lunch hour to take part, this is his lunch hour, I presume, to take part in this Ask the Expert session. So welcome, Dr. Trivedi. We're really grateful for your time. We've had some questions on email, so I'm going to take those first prior to obviously this webinar starting. And the first one is about PSC and somebody who has gout. I have PSC and have begun to have bouts of serious gout, which is extremely painful. Could you advise on a suitable drug to help, as I'm nervous about taking something that will impact my liver? I also have UC and a J pouch after a total pan colectomy.
Sure, thank you. So gout, for those people who don't sort of know, it's a buildup of a compound called uric acid or urate, and they form these little crystals in joints, usually the big toe or the toes adjacent, sometimes in other sort of joints like the elbows and knees, but most commonly in the toes, and it can be really painful. Some people describe it as sometimes more painful than even if you've broken something. And it is treatable. It is very sort of easily treatable. Now, the trigger factors for it can be things like alcohol consumption, certain types of fish, and certain types of meats. They can cause your body to build up more uric acid, but some people, we don't find a trigger and it's just unlucky, and that might be related to their ancestry and genetics of people of certain origins. For example, people from the Far East are very predisposed to it. The medications that we normally use, so GPs will use various things to treat the episode of gout there and then, and other medications to reduce the risks of gout coming back at a later date. To treat the episode of gout in the here and now, most people would be advised to take an anti-inflammatory agent like ibuprofen. Now, we are cautious about using those in anybody who's got a liver condition because it can cause harm to the liver. Now, if that is the only thing that works for gout, then a short, time-limited treatment, the benefit would outweigh the risk. And we have said, if your GP has prescribed it to you and there is not another alternative that they can provide for various reasons, and I'll come on to those in a second, then absolutely take them, and we will just monitor your liver and kidneys and other organs in line. The second type of agent that we use to treat the gout in the sudden acute setting, as we call it, when it's active, are steroids, things like prednisolone, that can also be used. And they are safe to take in people with PSC, with a previous colectomy, with pouches. They have their own inherent side effects for anybody who's taken prednisolone, but the treatment course is short. It's not intended to be a long-term process. This is very much to get rid of the crystals and the inflammation associated with them. And the third commonest agent that we see prescribed is something called colchicine. Now, colchicine is something that it inhibits some of the cells in the body to turn over. So it's what we call a microtubule inhibitor, and it is something that's been around for for decades and decades. And there are even some studies to see whether it can help treat people with certain conditions. Now, with colchicine, the main thing that we get concerned about is that it can cause diarrhea. So if you have active colitis or active pouchitis, then whilst the treatment is short, if you are taking it and experience a change in bowel habit that is not manageable, you must stop, because it can cause diarrhea. And the second thing is it does dampen the immune system a little. So if you are on other immunosuppressive agents, for example, if you've had a liver transplant, then we must be cautious about the over-immunosuppression and interaction that colchicine can have with those agents like tacrolimus, for example. In terms of reducing the risk of gout coming back, there is an agent called allopurinol, which is the most commonest agent that we use to reduce the risk of gout coming back. It has to be used with caution if you're on azathioprine. That's the main interaction to worry about. Now, if you are on azathioprine and you need to take allopurinol, then do speak to your gut and liver doctor, because the azathioprine dose will really need to come down, and in some cases we would stop that and think of something else. So in the acute setting, steroids and colchicine, if they don't work and you really need anti-inflammatories, that is possible, but do it under the guidance of your consultant. And in the preventative setting, to reduce further risks, allopurinol is the mainstay of treatment, and we just don't tend to give it if you're on azathioprine. We would either stop it or lower the dose to very low levels.
Okay, thank you for that. And the next question that's come in before the session is also a question about medication, this time for cholesterol. I have familial hypercholesterolemia. That's a mouthful. When first diagnosed 10 years with PSC, I was ill for quite a while, stent in and out, and pancreatitis. I am on a low dose of ciprofloxacin and rarely have an attack. Sorry, my phone's going. I'm just going to turn off. Sorry about that. But did when I came off it. For some years, I could not tolerate a speck of fat, but I'm now able to have a more ordinary diet. Unfortunately, my cholesterol is above 8 and I cannot take a statin. I dread having a stroke or heart attack. What other medication could I safely have? Fibrate, ? I am 74.
Okay, thank you very much. So I'm sorry that you've had intolerance to statins. I mean, they are very good at lowering cholesterol, of course. Fibrates can lower cholesterol. They're not, however, they're more effective at lowering other types of lipids like triglycerides. Now, if your cholesterol is 8 and you can't tolerate a statin, and you've had confirmed familial hypercholesterolemia rather than high cholesterol related to PSC, which is very common and not as significant, then your doctor can refer you to what we call a clinical biochemist or a cardiologist. They can prescribe you agents a bit like what we call biological agents, a little bit like the MABs and the NIBs that we use for inflammatory bowel disease. And these particular agents are really good at lowering the cholesterol in a slightly more targeted way, with limited off-target effects like you would expect with statins and fibrates. They are very much sort of targeting the molecular processes that cause cholesterol plaques to build up. Now, there are a handful of those. I'm not an expert in high cholesterol conditions, but we've got a couple of patients who do have familial hypercholesterolemia who are on these targeted biologic agents, some of which are injection-based and some of which are sort of based on tablets, but they are long-lasting and they can lower your cholesterol. But the summary is, do ask your doctor to say that, are you sure this is related to my familial trait or is it related to my PSC? And if they don't know, then they should refer you to a clinical biochemist at your local hospital for further input.
Okay. Great, thank you for that. We've got somebody joining us from Poland, so welcome. Somebody here has got 5 questions about strictures. I'm going to ask a few, and then I will probably come back to them at the end to ask the rest. Can a stricture be treated by any other method than ERCP?
So In PSC, people can develop multiple strictures. These are narrowings in the tubes that drain bile, the bile ducts. And we do not, for the vast majority of people, we do not advise treating them with an ERCP. The only circumstances where, in my experience practice, that we would treat is if there is a significant dominant stricture, one that stands out loud and proud above the others. And it may be that you have multiple small strictures that are not impeding bile flow too much, or that you have, but you've got one that is very, very tight and to the point where it's really narrowing the diameter of your bile ducts. And it's only when those dominant strictures are present together with either A, symptoms of itching, and B, abnormal liver blood tests like a high bilirubin, you're jaundiced with it, or there's been a deterioration in other liver biochemical parameters, where we would say, we see this on your scan, you have symptoms and you have abnormal liver blood tests. When we see the combination of those things, that's where we would refer somebody for an ERCP to open it up. Now, there may be cases where it's only on the scan that we see that happening, and we see the strictures getting narrower and narrower in one or two at the very most particular areas. And under those circumstances, we would still intervene. So this ERCP that's mentioned, it's a telescope test that you have down your mouth through the stomach, and it views the bile duct as it enters the small bowel. We then pass a little wire, often with a balloon at the end, to open up any strictures. Now, that is very much sort of the only real way of opening up the strictures in people with PSC. There is a technique that we use after transplantation, which is less commonly used before transplantation, and that is where, rather than putting a telescope down the top end, we go through the side of the liver, so a little bit like a liver biopsy. So an incision is made at the side, just sort of below your rib cage, or between the lower part of your ribs, and an X-ray doctor called a radiologist will identify where the bile ducts are, and then put a wire and then a balloon in to open up those narrowings. But that is very infrequently performed. We only perform it in Birmingham in people who've had liver transplants. We don't perform it in people with PSC who have not undergone liver transplantation. There are, of course, times where even if having an ERCP, it doesn't necessarily fix, this is not a permanent solution. This is a temporary opening up of the bile ducts. The strictures, the narrowings recur, they recoil back. And if they're recoiling back and the symptoms associated with it, the blood abnormalities associated with it keep on recurring, or even if despite opening those strictures, the person still has symptoms, their liver bloods are unchanged, in that case, we would say the ERCP has no benefit. And if somebody has multiple strictures in their liver, too much or too high for the ERCP scope to access, we would say ERCP has no benefit. Under those circumstances, we often advise people to take long-term antibiotics to reduce the risk of infection. But if the liver function is compromised and the person is permanently jaundiced or has other signs of where their liver is not really passing its MOT, then the liver transplantation is the only thing that we would have left in our armory, and that's not because the liver's not working, it's just because the drainage, these bile ducts, are too narrow and too blocked, and it's not possible to treat them by any other means. So ERCP is the mainstay for a small group of people. We can do it percutaneously through the side of the rib cage in some, but it's not widely practiced. And lastly, perhaps the most important message is most strictures that we see in PSC are not amenable to PSC and don't need to have an ERCP. And if you've had an ERCP that's not worked, then I wouldn't pursue or persevere with repeated ones again and again. It may be that a larger intervention is sort of as needed.
I think you've answered most of the other questions as part of that, of answering that question. But one of the questions is how prevalent are strictures in PSC patients, and what proportion of them are treatable?
That's a very good question. So, I mean, most people will have strictures. I mean, that's partly how we diagnose the disease. It's either irregularities in the bile ducts or strictures. So that is how the disease is picked up. It is strictures in the bile ducts. In terms of how many of them are treatable, so some centres that do lots and lots of ERCP, they will attract lots of people where they believe have treatable strictures, and they will say rates of high as 40 to 50%. In Birmingham, whilst we do this procedure, we see people for not just stricture dilatation, but for transplantation, for clinical trials, and for people at the start of their journey with PSC. So we see all comers. In our practice, we actually think it's much less common. So I'd probably say it's probably going to be about 1 in 10 people we would see that we would have strictures that we would say, actually, this is something that might be amenable to an ERCP, but not all of those people need to have it done because they don't have symptoms, and these strictures remain stable for many years. So actually, in terms of strictures that need treatment, as such, I'd say the numbers perhaps sort of even smaller. I'd probably say it's about 1 in 20 or 1 in 25.
Okay, thanks for that. We have a question about the fecal transplant Fargo trial.
Mm-hmm.
Give us an update on that.
Yes, so there is lots of data about the gut microbiome in people with colitis and people with PSC, who to show that the gut microbiome is different to individuals without any form of liver disease, people with other liver diseases. And there is data in animals to show that if you change the gut microbiome makeup, you can reduce the chances of PSC developing in those animals. And you can also treat active inflammation in the liver and in the bile ducts in those animals by purely changing the gut microorganisms that are present in these mice. In the human setting, there is evidence that in people with colitis who are cycling through many different medications, doing the same thing, changing the gut microbiome, can also switch off the inflammation in the gut. So that led us to raise the question, well, can it also have some benefit in the liver? So to do that, we've starting a trial which is going to have 3 sites in London, 1 site in Oxford, 1 site in Birmingham, and 1 site in Norfolk, Norwich, where we will recruit people who have PSC and colitis, or if they've had a colectomy in a pouch, those people can also participate. And those individuals will be randomized. So half the group will get a transplant of microbiota from a healthy person's colon, and the other group will get a placebo, which doesn't contain any active organisms. And we will see whether that has improvements in the liver blood tests, whether that makes improvements in the quality of life and improves colitis activity. We are hoping to open imminently. We are waiting for the hospitals that are sort of in those locations to give us the green light. The way the system works, you have to apply to get funding. When you're successful at getting the funding, you have to then prepare all the regulatory and trial documents, which takes 9 to 12 months. You have to then submit those documents to the UK regulators. They say 40 days, but usually it's 6 months for them to get back to you. And they got back to us and approved the study to open in the UK back in October. And we are now waiting for our hospitals to also give us the green light. So that is the final step before we can officially open. I'm always trying to be more optimistic, and every time Paula and Martine and others sort of ask me, I said, yeah, we'll open by December. I'm still hopeful that we will. I did earlier on say it would be end of November, but we're at that now, and we haven't yet got the green light from the hospital. But once the hospital have given us the green light, then we're good to go. So it's a very much an any day now type situation.
Thank you for that. And just on research or and clinical trials, actually, this question has said, I saw the news about the spring trial today, and is there an update on Integris?
Yes, so the Integris trial was a study by Pliant Pharma. They presented some of the interim findings, which were quite excited about. They were presented at the annual American Liver Meeting a few weeks ago. Now, this was using a compound that is supposed to inhibit or at least slow the buildup of scar tissue around the bile ducts within the liver. And it's the scar tissue that really determines whether the liver loses its function or not. So that trial had 1 group receiving placebo, so a dummy pill, and 4 different doses of this compound called bexotegrast, or Bexo for short. The results of the first 3 doses compared to placebo were presented, And what they showed was that circulating blood markers of scar tissue formation from the liver did not go up over time, over 12 weeks, in people who received the active compound. And the higher the dose, the lower the rise was. But in the people with the placebo group who received the dummy pill, they continue to have very high rises in the circulating marker of fibrosis called the ELF score. So it certainly seems that this compound is doing something. It's certainly reducing the amount of circulating markers of fibrosis in the blood. That was what we call a phase 2 trial, and the spring trial is very much the a phase 2 study as well. We are still waiting for the readout of the highest dose of the bexotegrast, Integris, trial, which will hopefully read out towards the start of next year. And once those results out, then we would very much be keen to move into what we would call a phase 3 trial, which would be a definitive study before this compound can be hopefully enter the be licensed for the treatment of people with PSC. Now, regulators who approve whether a drug can be licensed or not, they don't tend to like blood-based biomarkers only, and they tend to like things like normalization in MRI or improvement in liver biopsy findings and features such as that with these compounds. They do also like accept if it improves quality of life, of course, then that is also something that will help a compound get over the line and become available to all of you.
Great, thank you very much for that. Why does PSC adversely affect the gallbladder? And is there any medication that can be taken to support the gallbladder that is liver friendly?
So in terms of how does it affect, so PSC is fundamentally a condition that affects the bile and the tubes that drain bile from the liver, and any excess bile that is built up will be stored inside the gallbladder. This is like a balloon type structure that sits beneath the liver. You don't need the gallbladder. I mean, lots of people have it removed, like both my parents have had theirs removed. It's like an appendix. It's a slightly vestigial organ. It does have a function, of course, to store excess bile, but it is not necessary to have one. In terms of why does it affect the gallbladder, some people believe that the composition of bile, because it's different in people with PSC, that damages the lining of the gallbladder. Others recognize that the lining of the bile ducts and lining of the gallbladder, which is very similar, those particular structures are different. That's where the problem starts, and compared to the problem starting in the bile itself. And as a result of the lining of those things being different, just like the lining of the bowel is different, and hence the association with inflammatory bowel disease, any condition that affects the bile ducts draining the liver is also likely to affect things that are made of the same grit, say made of the same stuff, like the gallbladder, like the bowel. And that's why we ask people to have an ultrasound scan every year, particularly if you've got a gallbladder inside, because there is a risk that you might form polyps in the gallbladder, which would then lead us to remove it. And if people have got symptoms from gallstones, which more than 40–50% of people do above the age of 50 years old, particularly women, sadly, then we have to, then we advise people to have the gallbladder removed.
Thank you for that. Hi, for patients who receive a liver transplant, should they anticipate their ulcerative colitis will improve post-transplantation?
So can you repeat that, please? Sorry, I didn't catch the beginning.
For PSC patients who receive a liver transplant, should they anticipate their ulcerative colitis will improve post-transplantation?
Not always. I mean, 40% of people who have got PSC and colitis, their colitis tends to get worse after transplant. And I'd say about 30% of them it's unchanged, and the remaining 30% it will improve. So it really is you can pick any of those three trajectories, but so roughly a third of them get better, roughly a third of them it stays the same, and just over a third of them it can get worse. So it doesn't always get better after transplantation. What I would certainly say, and I'm a firm believer of this, is that having the colon removed is always better for your liver the earlier it's done. So if somebody is having difficult to treat colitis and they've not really having colitis control with 1, 2, 3 agents before they, then I would normally have a much lower threshold to advise them to have a bowel surgery, having a colectomy, colon removed before, and that's because we recognize that there is no licensed medical therapy for PSC liver disease, and the condition progresses. And if the colitis is getting more difficult to treat, it's almost like two runners running at the same sort of pace, and eventually one of them is going to trip the other one over. So because we can't yet slow down what the liver does, but we do have an effective intervention to stop colitis in its tracks, which is surgery, and we also have newer agents available. We would say that if it's very difficult to treat, take that out of the equation. And we also find that having bowel surgery prior to transplantation, particularly people who have a stoma, that really, really reduces the risks of PSC coming back in the liver transplant. It almost takes it away completely. So there are advantages of bowel surgery prior to transplantation, provided the liver can cope with that operation. But the short answer is, it's not guaranteed that the colitis will stay under control or get better after transplantation.
Thank you for that. What causes the tenderness to the abdomen area with PSC? Is it the actual liver that is tender to the touch, or the surrounding tissues?
So the liver doesn't have any nerve endings per se, so it's always slightly puzzling why people get pain associated with PSC. And the two or three plausible reasons are: one is that the liver's capsule, so the shell that surrounds the liver, that can stretch in people who've got inflamed liver bile duct conditions. The second thing that sometimes can cause pain is if you have gallstones and you've had bouts of inflammation around the gallbladder, that can cause tenderness. And lastly, because this PSC is a condition where you have strictures, you have narrowings in the bile ducts. Bile finds it quite difficult to travel through these narrow pathways, and particularly if you've had stones or inflammation or infection associated with those narrowings, that can make the pain symptoms worse. So we don't know the exact answer. We recognize there are no nerve endings in the liver, so it's either the stretch of the capsule, that's the shell around the liver. If you've got stones in the gallbladder, then bouts of inflammation can make that area tender, or it's going to be the tubes that drain bile from the liver where the problem is, and it's just purely the presence of the narrowing, really. It's important to recognize that if you are getting pain, that's in other areas of the body. So individuals with very advanced PSC, cirrhosis, particularly on a liver transplant list, the neighboring organs can also become enlarged, like the spleen, which is your liver's neighbor. That can also swell, and that's on the opposite side of the body, on the left. That can sometimes cause a bit of pain. And of course, in people who've got inflammatory bowel disease, we don't anticipate you will have pain. It's unusual, but if your colitis is very active, then your abdomen may become a bit more tender over the course of time.
Thank you for that. Questions about fatigue, medication around fatigue. Can ERSO help fatigue? And another question, but related, is: are there any medications that help fatigue?
So unfortunately, ERSO doesn't tend to do a great deal for people with PSC, I'm afraid. I mean, it certainly can help improve liver blood tests in some individuals, but there is no real data to show that it slows the rate at which PSC progresses. There is some historical data showing that in people who normalize blood tests by whatever means or improve their blood tests, then long term their outcomes are better. But that's irrespective of them taking ERSO. It doesn't tend to help fatigue in large scale studies either. But there are some people, a couple of people who have taken it and they've felt better, their liver blood tests have got better. And in those people, we don't deny them, we don't stop the medication, because what is applicable to the broader group of people with PSC may not necessarily be applicable to selected individuals. But overall, there is no data to show that it helps with fatigue. Now, in terms of other medication, I mean, fatigue is a very difficult symptom to treat, and it's not the same from one person to the next. Some types of fatigue relate to what we call central components, whereby people can get brain fog they feel that their thoughts aren't as connected with what is sort of as they would expect, or that as they were when they were younger. And that sort of impairment sort of can be associated with sleep disturbances as well. And there are other types of fatigue where sort of the muscles that you have, the sort of ache, sort of when they, how should I phrase it, when they exercise, when they move around, and the acid levels build up, and they don't in everybody, but in people with PSC, they don't tend to normalize so quickly. So that's what we call a peripheral fatigue. So they get fatigued with minimal physical activity. There is some data to show that graded exercise interventions, resistance-based and aerobic exercises can, even if you are very physically active, your muscles can be retrained and can help with fatigue severity. So that is one of the few bits of evidence that we have. If people are having quite difficult sleep patterns, for instance, they're finding it difficult to stay awake during the whole day, then there are some medications which haven't been proven in big trials, but there are some individuals who benefit from. So there's a drug called modafinil, for example, which can help people try and stay awake. And so very few people in our program have actually tried those medications. It can help in some people, but for the vast majority, it doesn't. It's a bit like ERSO. But if sleep and be feeling sleepy in the day is the main issue, and you don't have advanced liver disease, you don't have cirrhosis, we have given things like modafinil. But above and beyond all, it's looking for other contributors that might be more common in people with PSC, such as vitamin D deficiency, B12 deficiencies, iron deficiencies, thyroid dysfunction, gluten intolerance, trying to find those particular coexisting factors that we know occur more commonly in primary sclerosing cholangitis than in health. But there's no other one-size-fits-all medication that can help with the fatigue, I'm afraid. The exercise programs that have been studied are perhaps the most have got the most evidence behind them.
Okay, thank you for that. This question about giving up smoking. I want to give up smoking and want to know what effect nicotinell gum and lozenges may have on my liver, please. My doctor is no PSC expert, so I'm asking you. Thank you.
Okay, so that's a very good question. So I'm going to give a very controversial answer here, and I'm sure there will be some feedback here, and I'm happy to take the flak from it. What we do see is that smokers, for example, they tend to have less aggressive colitis and less aggressive PSC than non-smokers. Now, that doesn't mean that I'm advising everybody to start smoking, because the negative health consequences of taking up smoking are certainly outweigh whatever benefits people can get from them. But it's important just to ensure that colitis is well controlled and that the liver tests are all okay before you start. Before you make that lifestyle change. The second thing is that lozenges and gums do contain some of them contain artificial sweetener type compounds like sorbitol. They will not affect your liver in a negative way, but these sort of artificial sweetener type things, broadly speaking, PSC aside, are not good for health in the long term. These are similar to sort of artificial sweeteners and compounds that you get in ultra processed foods and soft drinks and things like that. So from a general health point of view, absolutely anything you can to stop smoking is advised, but and we would normally say these two things just as for a short term, so for a few years is good, but certainly not for sort of decades and decades.
Okay, thank you for that. There's certain foods we get these questions quite a lot on these. People want to do as much as they can to help themselves. Are there certain foods or supplements that you would recommend adding to the diet of a PSC patient?
There's nothing that we would there's nothing that we would say you have to add to your diet. We would normally say a general healthy, well-balanced diet, minimize ultra processed foods, artificial ingredients, rich in fruit and vegetables, plenty of exercise, good good sleep pattern. Those sorts of things are very good for metabolic health, which can impact what your liver does. There are some studies in PSC and in liver disease as a general to show that having 3 to 4 cups of coffee a day is beneficial, prolonging life expectancy, reduces scar tissue formation in the liver. So if people and it doesn't have to have caffeine. It doesn't have to be. It doesn't have to be a caffeinated beverage. Can be decaffeinated. It's not the caffeine that's the main issue. It's a main benefit. But we would certainly say that if you are somebody who likes a little bit of coffee, you can increase your intake to 3 to 4 cups a day if you're not having that much already. And if you are somebody who alternates between say tea and coffee, or soft drinks just to keep yourself awake during the day, then we would certainly favor coffee over the other two types of drinks that you have. But that's a general health thing and a general thing for liver disease. There is some association that it might reduce the risk of scar tissue formation. But apart from that, there are no particular dietary supplements that have evidence based. There is a study that's just been about to start in the Scandinavian nations, led out of Norway, to show that vitamin B6 supplementation, study vitamin B6 supplementation. So what they found in their cohorts are that people who were very low in vitamin B6 had worse outcomes, more likely to need a liver transplant, and so on and so forth. And now, whether it's the advanced nature of their liver disease that led to the B6 deficiency, or whether it's vitamin B6 deficiency that was associated with the liver disease progressing, we don't know. But there is going to be a trial of vitamin B6 supplementation there, and as a general health thing, we can't readily measure vitamin B6 in routine clinical practice. It's very much a research tool, so it's not going to be available at every hospital. But if you get some vitamin B6 supplements, don't overdo it. But even like multivitamins that have got vitamin B6 in them, I think that's a good idea.
Well, that's great. If a PSC patient is not taking any type of medication and does not have IBD, can a low dose aspirin be taken daily to reduce inflammation?
So there is some data. So the background story with aspirin is that there are large population level studies, in general population level studies, to show that individuals who take aspirin have a lower risk of bowel cancer. And there is some data to show that people who take aspirin have a lower risk of bile duct cancer, and that is as well, so cholangiocarcinoma. So it then begs a question that in people with PSC who are at risk of these two cancers, and does aspirin help? Now, there is a trial that's about to open in the UK, national trial, hopefully available to almost every hospital in the UK, looking to see whether aspirin actually does reduce the risk of cancer. So not just has an association, but actually it's the aspirin itself that's reducing the risk of cancer. So we're looking to recruit just over 900 people with PSC to that study. So if this individual is interested, I would certainly make them keep a lookout for that. Now, again, a slightly controversial answer. There are lots of people where I've mentioned this trial too, who are saying, well, if that's the case, I'm just going to go and take an aspirin because it's very well, studied. We know what the safety profile is. Now, that's completely up to them. It's not within my remit to say that they shouldn't do that and definitely do the trial. But there is some benefit from existing data that a once daily low dose aspirin, 75 milligrams, may help people. I would always favor people doing a trial just from a scientific perspective, but I completely understand if people want to take an over-the-counter aspirin, rather because they may not favor taking part in the trial, and the other benefits you get within a trial, like regular monitoring and stuff, may not be permissive to their lifestyle.
Thank you for that. Diagnosed with mild colitis, asymptomatic, following on for PSC diagnosis earlier this year. Is it recommended to start taking Pentasa daily to treat the colitis for patients with PSC? Naturally, this person says, I'm very keen to optimize my liver, and he's already taking ERCP daily. Yeah.
Okay, so I'd argue actually that the Pentasa, so that's the trade name, one of the types of mesalazine that we can get. So mesalazine is a mainstay of colitis treatment. It's a medication very useful for mild to moderate colitis. I would actually say that it's more important to take that than it is to take ursodeoxycholic acid. I mean, there is very little evidence to show that ursodeoxycholic acid will prolong or favour liver health in large groups of people. But in this individual's case, if their liver bloods have got better and they're tolerating it, absolutely stay on it. But I would argue that the mesalazine, the Pentasa, as they refer it to, that is more important. So yes, aiming for complete normalization of what your colitis looks like, so it looks like you just don't have colitis, is important. And if they don't have any symptoms, then mesalazine, and it's very mild colitis, then yeah, mesalazine is absolutely the right thing to start.
So why do some patients with classic PSC have stable PSC for many years compared to others that progress to transplant very quickly? Due to diet, medication, healthier microbiome, severity of IBD, genetics, or just good luck?
We don't honestly know the answer as to why some people do badly, some people do worse. We have markers in the blood, markers on imaging that tell us that the condition is progressing. In terms of things that, when it comes to the people themselves, what we recognize is that younger people, and you can define young in any way you want, but the younger you are, the PSC tends to be more aggressive. So the things that keep me awake up at night are people in my clinic who are in their late teens, early 20s, 30s, early 40s, more so than people that I see who are in their late 50s, 60s, and 70s. And that's just because as a younger individual, their condition tends to be more aggressive. They have that many more life years ahead of them that we have to support their PSC through, and some more chances of things happening. And it may be because they've got a more aggressive immune system, and we recognize that PSC is an autoimmune condition. So as a result of that, that's why their PSC is progressing. So young age is the first thing. The second thing is there is some data now emerging from the Netherlands and which will be validated elsewhere, which shows that people who have got very early stage PSC when they're diagnosed, if they've had a colectomy and have kept an ileostomy rather than had a pouch, or in people who've kept the colon in, actually they have a much slower or virtually absence of any form of disease progression. So certainly removing the colon at a population level was a signal that was shown that reduces the risk of PSC progressing, and that we see that even after transplantation, as I mentioned already, it reduces the risk of recurrence. So there is certainly something in the bowel that is habit. So people who have had a colectomy less often progress than people who don't. We do see that women have about a 25% lower risk of their PSC progressing and developing complications. We see slightly more aggressive sort of PSC in people of non-white race, so people of black race, people of Southeast Asian extraction. Their diseases can also be a bit more aggressive. So there are lots of those types of demographic factors. The age, your sex, your race. And also, importantly, the type of inflammatory bowel disease treatment, surgical, non-surgical, that you've had. Lastly, I just wanted to mention that there are different types of PSC. So there is the classical PSC, which is what this person mentioned, but there's also what we call the small duct PSC, where the MRI scans look completely normal, and we only see PSC on the biopsies. And in those individuals, where it's only in the biopsies, whether that's a very early form of classical PSC yet or not, I mean, we don't know, but that doesn't tend to progress very much either. So the type of PSC that you have also has an influence.
Thank you for that. So this is a question from a cold Chicago morning. Have you seen a pattern? Somebody's in Chicago. PSC patients also having eosinophilic esophagitis. We've learned of other children who also have that combination here in the States, my son included.
That's very interesting. I mean, and yeah, well, thank you very much for joining us from Chicago. Big Chicago sports fan myself. So the big return over the weekend for those who are fans of combat sports in Chicago. Yeah, the eosinophilic esophagitis, that's a condition which we believe is almost like an allergic type reaction to certain types of food groups, wherein the esophagus, lining the the lining of the esophagus, where your gullet, that is infiltrated by these cells called eosinophils, and they very much infiltrate in response to an allergic type reaction. So it's not like an allergic reaction where you swell everywhere. It's just like an intolerance to certain types of food groups. We haven't seen an association in adults, and I'm an adult physician, but certainly in young adults who transition from pediatrics, we haven't seen any evidence that or associations that between eosinophilic esophagitis and PSC. But we haven't done endoscopies and biopsies in everybody, but the few people that we haven't really seen any association between it, if I'm truthfully honest. There are other types of, much rarer types of sclerosing cholangitis where we do see lots of eosinophils infiltrated. So if this so it may be important. It is certainly worth asking your local physician, saying, just to be sure that, are you sure that this is PSC? And if it is PSC, is it, if it is not primary sclerosing cholangitis, is it a secondary sclerosing cholangitis? And I'm only asking because I've got this eosinophilic esophagitis here as well, and there may be a link. And they can certainly look, if you've had a biopsy, for example, to see if there are lots of eosinophils in your biopsy too.
Thank you for that. Can COVID virus trigger PSC?
I haven't seen it trigger PSC, but what I have seen is a different, in people who had very bad COVID to the point where they've needed intensive care admission, the oxygen starvation that these people experience, that can lead to a secondary sclerosing cholangitis. It's what we call sclerosing cholangitis of the sick person, but really that's a reflection of hypoxia, not a reflection of just having the virus, if that makes sense. And we can see that with lots of different types of sickness. So we have seen sclerosing cholangitis in people with COVID, not due to the virus itself, but just the physical state. We have seen people who've had vaccinations, though, COVID vaccinations, which have triggered and unmasked autoimmune liver injury. So that is certainly something that we do see. It's very uncommon, but it's well recognized. And there are some people who've had liver transplants and autoimmune liver diseases where their condition can flare transiently after vaccination as well. We don't tend to see virus doing the same thing.
I'm about to start the adapt to see if certain food additives affect Crohn's disease. Do you think food additives can also affect PSC?
I mean, we would think so. I mean, there are lots of similarities between PSC and Crohn's disease, at a genetic and a microbiome level, and there is a whole realm of interest as to whether food additives are the cause of why we are seeing more PSC, why we are seeing more Crohn's disease, why we're seeing more of lots of other immune-mediated conditions. So I would love to sort of see if there are. I would love to sort of study this further to see if there is a particular food additive. I can't say for definite yet, but I certainly would advocate minimizing food additives and ultra-processed foods if you've got PSC or any form of liver condition.
For that, is it fair to say the results of a FibroScan, the ultimate test of whether liver is deteriorating towards advanced liver disease, eventually requiring transplant, i.e., if liver scarring is above normal and deteriorating, even very slowly, are you on the road to probably needing transplant at some stage?
So I didn't quite understand that question. Can you just repeat that?
Is it fair to say the results of a FibroScan, the
yeah,
test of whether the liver is deteriorating towards advanced liver disease, eventually transplant, i.e., if liver scarring is above normal and deteriorating, even very slowly, are you on the road to probably needing transplant at some stage?
Understood. Okay. So I mean, a FibroScan is like an ultrasound machine, but it gives a picture, gives me a number of the liver, indicating how stiff and scarred it is, rather than a picture like the ultrasound does. The thing I'd say though about the the FibroScan, it is a proxy for a liver biopsy. So so the gold standard of knowing how much scar tissue there is in the liver is taking the liver out, looking and measuring how all the scar tissue is. But we can't do that for obvious reasons. We can't just take the liver out to look at it. So we try to sample it with a needle, with a biopsy. Now a biopsy sample is about what, 1/100,000th of a liver. And a FibroScan scans a little bit more, but that's still about 1/150,000th of a liver, and it's only in that particular area. So the rest of the liver, it doesn't sample automatically. So it's not the ultimate test, is the first thing just to say. But there is good association between rising values year on year in a FibroScan and the likelihood that somebody's going to need a liver transplant. Ultimately, the thing that determines whether somebody needs a liver transplant is going to be whether the liver has lost function. So whether somebody has become permanently jaundiced, their tummy has started to fill up with fluid because the pressure in the blood vessels going to the liver is too high, whether they develop confusional states because the liver can't clear its toxins, or whether they have ongoing bleeding because the blood vessels in the gullet have become really swollen because the liver's not working properly. It is not going to be your FibroScan value that will determine your need for transplantation. That tells me the level of stiffness and scarring within your liver. We would use that as a proxy to say that, yes, your liver scarring is progressing and the likelihood of you needing a liver transplant is going to go up. But we wouldn't say that we're not going to base the decision to list you on the FibroScan result alone. And there are lots of other things that can affect the FibroScan reading. I mean, a variation of 1 or 2 points from year to year is expected. That's just a variation in the test. Just like if you weigh yourself in the morning and evening, you'll get some variation. The other thing is if you've got very tight dominant biliary strictures, going to our very first question of the day, or one of the first questions, that can also push your FibroScan reading up.
Okay, and I've just realised that Dr. Trivedi, you have to leave now. You've obviously got a very busy schedule, so we will close the webinar now. Thank you so much for your time, and we look forward to you joining us again. Thank you so much to everybody who's asked a question. We got round to answering most of them, not all of them, unfortunately, but most of the questions today. And I do hope you've got the answers that you require as well. Our next session is on December the 6th, and it's about liver transplantation. So I hope you can join us then. Thank you so much, everybody who's joined us today.
Thank you all.
Bye-bye.
Thanks. Bye-bye. Bye.